Welcome to another episode of MedTalk. Today we have special guest Dr. Amit Chakrabarty, who is a board certified practicing urologist in Missouri and also actively involved with American Association of Physicians of Indian Origin, AAPI, for the past 15 years and is a current secretary of AAPI. Today we will talk about prostate cancer, low testosterone and infertility in men, benign prostatic hyperplasia, and other urological disorders pertains to men, which has not been talked a lot. Welcome, Dr. Chakrabarty, to MedTalk.
Thank you very much, Tusharji, for having me here. Thank you, IndusTV. I'll be glad to answer all those questions and myths and debunk some myths about all the urological diseases by men. And a lot of things are taboo and not covered usually and not talked about. I would be glad to shed some light and answer those questions which you have, and hopefully the public will gain from this.
On how prevalent prostate cancer is and who are at risk of getting prostate cancer, specifically our minority communities such as South Asians, Hispanics, and African Americans.
Prostate cancer in America is the second largest incidence is second highest after skin cancer, and second commonest cause of death after lung cancer. So prostate cancer is very prevalent. Fortunately, amongst Asians, the incidence is less. African Americans and people with a family history of prostate cancer, the incidence is higher, and we start screening them at an earlier stage.
So, what are the current recommendations on cancer screening, and who should get the screening, and when is the baseline screening should start?
That's a very good question. It's been a moving target. There's been a lot of controversy on this issue, and back and forth between urology community, general practitioner, internal medicine community, and cancer society. We initially, when we had PSA, we used to start screening at the age 50 and go on till 75. We realized that we are actually detecting a lot of cancers which are indolent. You may not know that a lot of prostate cancer, people may have it, but they don't die from prostate cancer because prostate cancer is usually a slow growing cancer. We have done studies which showed people at age 80% of people, if you biopsy their prostate, will have prostate cancer. I was involved in this study when I was doing my residency at Wayne State University. Having said that, then we realized that we shouldn't shift the pendulum too much to the right. People were advising against getting PSA screening. When they started doing that, after about 5 to 10 years, we realized the mortality of prostate cancer was going up. So now we have come to a fair medium where we realize that we will start screening prostate cancers at around age 50. If it is less than 1, we can do the screening every 2 to 3 years rather than yearly. If you have a family history of prostate cancer with a first degree relative having had prostate cancer, especially at a younger age, or having died from it, or if you're African American, you should definitely get screened at 50. Though the other people may wait for a little longer, African Americans sometimes may get start to get a screening, maybe a baseline PS at 45. Having said that, if your PSA is less than 1, you can relax and not get a yearly PSA. When to stop getting a PSA? That's the most important thing. People used to say it was 75. I say 70 years old. Nowadays, most experts say after 70 years old, if your PSA is kind of on the low side, we shouldn't get any more PSAs. You don't have to. Another thing which is very important is that it's not the absolute number of PSA. We have always had a cutoff of 4, and we thought that that was the magic cutoff. But right now, we know there's something called age-specific PSA. In other words, if you're 55 years old and you've got a PSA of 3, I'll be more concerned than if you're 70 years old and your PSA is 3. So that's called age-specific PSA. There's something called PSA density, which is just to say PSA is prostate specific, not cancer specific. So even if you have a large prostate, your PSA may be higher. So what we call is PSA density. That means we take the PSA divided by the volume and find out whether that is significant or not based on the volume. But the most important criteria, which according to me is the PSA density. For example, if you're 55, you get a PSH 1 today. In 1 year, it goes to 2, and third year, it goes to 3. That's a PSA velocity is very high. You need to go to a urologist and have this checked up. So there is a little. It's not clear cut that magic number of 4 does not exist anymore.
What would be the next step to confirm a diagnosis and other workup for cancer? Uh, can you explain that? That is always confusing for many, even internal medicine physicians.
Yeah, that's very right. I mean, basically, elevated PSA does not mean that you have prostate cancer. PSA can be elevated with infection like prostatitis. If you have had an instrumentation, somebody put a catheter in you and you're admitted for urinary retention or whatever the cause is, the internal medicine person advises or orders a PSA and it's elevated. That is not because he's got prostate cancer. It's elevated because you catheterize the patient. That is very important for patients and even physicians to realize that if you have an instrumented prostate, if you have a catheter placed in the person, you should not get a PSA immediately after. It may be falsely raised. So PSA is, like I said, is not cancer specific. It's called prostate specific antigen. Prostatitis, instrumentation of the urinary tract. Even if you have, sometimes you get a PSA right the next day after having sex. Sometimes the PSA goes up. There have been anecdotal reports that if you're an avid biker and you do one of those fast biking and your PSA may be elevated falsely. So in other words, there are a lot of instances the PSA can be elevated, not after a simple digital rectal exam. That used to be a myth, but we don't consider that to be a significant point anymore. But PSA, when it's elevated, just means that you have to be evaluated. It's just like a woman getting pap smear, which is positive, you get a biopsy. If you have got a mammogram, which is positive, that doesn't mean that you have cancer. Nobody can hang their hat on the fact that your PSA is elevated, you have cancer. You have to have a prostate biopsy to diagnose it. Now, the good thing about diagnosis, men are wimps. Women go and get these biopsies done without any problem, but men really have a problem getting the PSA done, getting a digital rectal exam done, because for some reason that is against manlyhood. I mean, that's against our nature. Unfortunately, that's a lifesaver that needs to be done. We need to educate people. Now, having said that, prostate biopsy is very simple. It is done in the office under local anesthesia, and it is painless, and it actually takes about 5 minutes to do. The only side effect, because we go through the rectum to get the biopsies, we make sure that you get antibiotics before and after, and there's a chance of sepsis, which varies from different place to place, and that's the only thing which you need to worry about. If you've got resistance to the fluoroquinolines, which we study on Cipro or Levaquin, if you're resistant to that, you may get sepsis. After diagnosing prostate cancer, we need to determine whether the prostate cancer is something which is aggressive or non-aggressive. Because remember, I told you, a lot of prostate cancers are indolent. So we have a score called Gleason score. That's a grade of the prostate cancer. And based on that, we can give a fair estimate that, hey, your cancer is something which is going to kill you or is going to be serious. You need to treat this, versus your cancer may not be that serious. We can perhaps wait and follow your PSA and follow what's called an active surveillance, which is following your PSA and perhaps repeating a biopsy according to the American Urological Association guidelines. However, if your PSA is very elevated or your Gleason score is very high, you need to rule out whether it's spread to the bones or lymph nodes. Prostate spreads to the bones or pelvic lymph nodes. So we get a CT scan of the pelvis and a bone scan to find out whether it's spread or not. So those are the things, diagnostic criteria which you do. There's another small thing which new people may encounter. There are some people who are not very comfortable. Their Gleason score is low, but they're still not comfortable in whether just doing nothing. There is something called genomic tests. There are 3 genomic tests which we can do, which actually gives you a risk stratification, whether your this Gleason score of 6, which is the lowest score, or quite low score, is it high risk, intermediate risk, or low risk? So the genomic scores are, though the jury is out, we don't have exact definition in the guidelines, but it will be in the guidelines very soon, that we can actually find out from genomic studies how much how aggressive that cancer is.
So that was wonderfully explained, Dr. Chakrabarty, the cancer screening as well as making the diagnosis. So let's say if somebody is diagnosed with prostate cancer, what are the options available at this time in cancer treatment? And also, can you tell our viewers about the advanced form of prostate cancer?
If your prostate cancer is of a Gleason score and you guys decide that we'll need to go ahead and treat the prostate cancer. So remember, we told you there are three options: active surveillance, radiation, and surgery. There are two other lesser used modalities called cryotherapy of the prostate, where we freeze the prostate, or HIFU is high frequency ultrasound, which is still in the experimental phase. It's not come into the mainstream. People sometimes do it. So I just refer to those. Active surveillance, where you actually follow your PSA every 6 months and repeat a biopsy every year, according to the American Urological Association guidelines. Those are for low grade cancers, people who are older or have other morbidities. We try to put them on active surveillance. Surgery or radiation. Radiation is of two types, basically external beam radiation, where you go 5 days a week for 7 weeks, 35 treatments, and get external beam radiation. Now, there are a few things extra for the external beam. There are something called cyber knife and other interesting advances of radiation, where you can get this radiation done much quicker. And there is something else which we do a lot, because the prostate is very close to the rectum. A lot of times people used to get side effects of the radiation scattering onto the rectum from the prostate, and they used to get rectal side effects and bladder side effects. Well, we have come up with recently, in the last 2 years, we have come up with something called spacer. It is a gel which a urologist injects between the prostate and the rectum, which actually separates the prostate and the rectum, so saves the rectum from radiation by the radiation therapy. And this gel dissolves itself in 3 months. So that's called spacer. Absolutely new. A lot of people don't know it, but that's a lifesaver. If you're going for external beam radiation, that's something which will save your rectum. The other kind of radiation is called brachytherapy, where we put seeds in the prostate. The seeds are radioactive seeds, and you place them under ultrasound guidance, and then that those seeds emit radiation and kill the cancer cells when the seeds are in your body. So there are pros and cons of brachytherapy, but one good thing is that very minimal side effects. There is no less incidence of impotence and other rectal side effects, which I just now talked about. Now coming to surgery. Surgery, I mean, there's always a controversy, which is better, radiation or surgery. Surgeons say surgery is better, radiation, people say radiation is better. But 10 years, there's no difference. After 10 to 15 years, surgery has got an advantage. If you've got more than 10 to 15 years life expectancy, you might think of surgery. Again, this is from a standpoint. So I'm a urologist. You can always get a different view from a radiation oncologist. Surgery is of three types. Surgery can be open prostatectomy, where we actually make an incision and take the prostate out, or it can be laparoscopic or robotic prostatectomy. We do it with a robot. That has taken off a lot. Majority of the prostatectomies, 80% of the prostates are removed today with a robot. The advantage of a robotic prostatectomy, it's a much precise surgery, and the nerves, most common side effect of prostatectomy or removing the prostate is the nerves which go for the erections lie very close to the prostate, and while you're taking it out, you might sacrifice the nerves, and there's an increased chance of impotence. Well, another side effect is bleeding, and the third side effect is incontinence. So we'll talk about that side effects, but to prevent or to try to spare the nerves, if robotic gives you amazing view, close-up view, you can literally shave the nerves of the prostate glands and give the patient a better chance of maintaining their potency. And also, robotic surgery traditionally is less. There's less blood loss, and obviously both the open and robotic prostatectomy has a small incidence of incontinence afterwards, which can be treated. which can be treated. It's not like something people have to live with. It can be treated. And cryotherapy is something where we actually put small needles in the prostate and freeze the prostate, and we see the ice ball grow with an ultrasound to make sure that it doesn't go to the rectum or the side, or any other organs, bladder or any other organs. That's cryotherapy. High flow, again, is experimental, and few centers do it, and Medicare doesn't cover for it, so we don't discuss that too much.
So there was wonderful information on cancer treatment, Dr. Chakrabarty. So how is the prognosis?
The prognosis of prostate cancer, if it's treated early, is very, very curable. If it is not treated early, I told you, it's the second largest killer amongst American males. So the key is early diagnosis and early treatment of those cancers which are aggressive. Onus falls on the urologist to weed out the ones which are bad actors. We call it rabbits or hares, and the tortoises or the turtles. So hares and tortoises, the slow growing, we don't have to worry about it. The fast growing, we need to make sure we take care of it. So the paradigm has completely shifted. Before, for higher score, higher Gleason score, 9 or 10, we used to actually say that just get radiation because the chances of cure is very low. Nowadays, it's shifted that we are saying that you don't treat the lower Gleason score and treat the higher aggressive cancers, but not the lower ones. It completely is a switcheroo. Since when I was a resident, we used to treat the lower cancers and send the higher cancers for radiation. Now we have changed it around. So that's how much we have evolved in the knowledge of prostate cancer.
So wonderful. So we always talk about prevention. Can someone prevent getting prostate cancer? Would you share some prevention tips?
Well, Tushar, I wish there was a magic pill. There is none, unfortunately, for prostate cancer. We have done several studies which included selenium, vitamin E, and so forth, lycopenes. None of those studies proved that they helped either ways. There were studies which they did on the proscar, the finasteride, tried to see if that prevented prostate cancer, because people knew that testosterone increases the aggressiveness of prostate cancer. Maybe it prevents. Well, that study went nowhere because though it showed that there was a lower number of prostate cancers in the study, but finally they found out that the cancers which were there were higher grade cancer or more aggressive cancer. Then another dutasteride, which is like finasteride, another company, Avodart, they also conducted the same study and tried to see if that medication would also give some. Maybe this study was flawed. Maybe we can find whether it can prevent prostate cancer, and it exactly showed the same thing, that the more aggressive cancers were diagnosed. In other words, there was kind of a corollary that if you take these, you may decrease the incidence of cancer, but the cancers which are detected are a much dangerous, much higher grade. So there is actually a black box warning. Primary care physicians should know this. There is a black box warning on Avodart and Proscar thing by FDA, that you have to tell the patients that taking this medication may increase the chance of you getting aggressive cancer. People prescribe Proscar and Avodart with impunity, but they don't know about this black box warning that you have to share with the patients, otherwise we may get into trouble. Having said that, low fatty diet, exercise have been shown that to improve the lessen the incidence of prostate cancer. If you're an African American and family history of prostate cancer, you've got a higher risk. You need to be aggressively screened and treated aggressively also. Those people have especially African Americans, have a more aggressive type of cancer and needs to be treated.
And I want to ask you a few questions regarding the benign prostatic hyperplasia, which is very common to men in this country, and I have seen many cases in India. Can you explain what are the common symptoms and how do we diagnose benign prostatic hyperplasia?
BPH is one of the commonest causes or reasons why patients come to us, any older patient. So prostatitis is the commonest cause when a younger patient comes, and BPH is the commonest cause why older patients come to you. Well, the symptoms are usually both either obstructive or irritative. So obstructive symptoms are straining to void, intermittent voiding, stopping and starting, incomplete bladder evacuation, and weak stream. These are the obstructive symptoms. The patient may have irritative symptoms like urgency, having to rush to the bathroom, frequency, having to go more often, nocturia, getting up night to go to the bathroom very often, and these are irritative symptoms. A patient may have a combination of both obstructive and irritative symptoms. Very interestingly, it's the nocturia which usually gets the patients to the hospital or the urologist's office most often. Sometimes their wives send the patients to the urologist saying that she wakes up every time he has to go to the bathroom. So sometimes it gets worse and they get what's called urgency incontinence, where they cannot make it to the bathroom and they leak urine. Also, it gets worse. They don't empty their bladder. We call incomplete bladder emptying. And sometimes they end up in the emergency room where they cannot urinate at all and they have to have a catheter placed. Um, so this is the whole scenario of BPH. And how do we diagnose BPH? When the patient comes to the office, I do ask a history, which I just now said. We have them fill out a form called AUA symptom score, or sometimes called International Prostate Symptom Score, IPSS. It is a validated questionnaire which actually grades the severity of your symptoms and the bother, how much bothered you are. Okay, there are people who are bothered by slow flow. There are older people who said that, hey, they don't mind sitting in the commode for 5 minutes and peeing. So, it's a bother symptom is very important. I asked them whether the PCP has started them on any medications or not. Flomax or tamsulosin is usually the commonest medication. They also can be started on Proscar or which is called finasteride, or dutasteride, which is Avodart. But I think the patients, if the prostate size is less than 40 grams, starting them on those medication, Proscar or Avodart, will not help unless you know that the prostate size is large and you have done a rectal exam. My primary care physician friends, you've actually done an ultrasound of the prostate or done a rectal exam. Starting them on finasteride is not going to help them, may hurt them. And I also alluded to you earlier that there is a black box warning saying that there is a chance that it may increase the incidence of a more aggressive prostate cancer. So you have to be very careful about starting them on finasteride or dutasteride. But Flomax is something which helps. Finasteride, dutasteride helps if the prostate is really enlarged, but it takes a longer time for it to shrink the prostate. Flomax is an alpha blocker which relaxes the muscles of the prostate and you get more immediate relief. So the patient I ask them whether they're on a medication. If they are not, I start them on a medication. If they're already on medication and it's not working and the PCP has sent them to me for that, then I do what's called a flow test called Euroflow, where I ask them to come back with a full blood. Of course, I do a rectal exam to make sure the size of the prostate, whether there is any nodules or not. I've already talked about that. Then I do a Euroflow test where they come with a full bladder, urinate on this commode, which is hooked to a computer, and gives me a tracing of the flow, which objectifies the subjective symptoms. In other words, the patient may say, hey, I'm fine, but his urination is very slow. And it gives me an idea that, hey, you're not fine. Also, at the same time, with an ultrasound, we check what's called a post void residual. That means after peeing, we check whether how much is left over in the bladder. It's called post void residual. Based on that, we decide whether the patient's treatment is working or whether he needs anything additional done. Now, if the patient's treatment is not working or he's bothered by the side effects of the Flomax, previously there was nothing, there was only surgery. These days, there is a bunch of things in between medication and surgery. So the patient doesn't have to suffer till he gets that symptomatic that he needs surgery. There are something called minimally invasive procedures in the office which is done absolutely without anesthesia, without surgery, and can help bridge the gap or can help kick the can down the road for 7 years or more. So these are, initially it used to be transurethral needle ablation, which we use radio frequency to kill the prostate cells, or transurethral microwave therapy, where literally we use the same microwave energy and heat the prostate to kill the prostate cells. All these are done under oral sedation and prostate block in the office. Now there are two new kids on the block. One is called Rezum, REZUM, which is the same, similar to the transurethral needle ablation. However, it is water vapor therapy. We actually inject steam we do a cystoscopy where we look inside the bladder and inject steam into the prostate to kill the prostate cells. And that has quite good effect. About in 2 to 3 weeks, maybe a month, the patient starts avoiding better. There's something called UroLift, which is actually called prostate urethral lift. It's literally staples which staple the prostate apart. We go through the bladder, into the urethra, into the prostate, and staple the prostate apart. It's called UroLift. So these are the new things. There are other very less commonly used, like water therapy, hydrotherapy, and stuff like that. But those are an alcohol injection, which some radiologists do. But that's not a commonplace in AUA guidelines. In AUA guidelines, you need to find out, minimally invasive is Rezum, which is the water vapor therapy, and UroLift are the latest in-office non-invasive therapies. And then if this doesn't work, or if you're for this, you need to have a little investigation. People can have to do a cystoscopy where you look inside the bladder to find out whether there is any, how the bladder look, whether there is any scar tissue or stricture, which may cause slowing of the urinary stream, and the treatment is totally different, a scar tissue of the urethra. And you have to do an ultrasound of your prostate to find out whether you fall within that range of prostate where you can be treated with this minimally invasive therapies. So once we have done that, if the patient goes for minimally invasive therapies, we use that, we do that in the office. If the patient is out, symptoms are more severe, or they are not candidates for this, or the prostate size is out of range, then we do take them to the hospital, and we can do either a regular gold standard TURP or TURP, where we actually shave the prostate out, like pouring an apple out from inside. We can use prostate vaporization techniques, and it has got much less morbid than it was before. We use saline as irrigation these days rather than glycine, so the chances of side effects are much less. Bleeding is less, though it can happen. Then there is something called laser of the prostate, which has the advantage that green light laser prostate can cause the prostate to open up or vaporize without causing bleeding. So if the patient is on blood thinners, Coumadin, or any other blood thinners, I can take them and do a green light laser prostatectomy without taking them off blood thinners. Very few cardiologists, very few internists know this, and we have had patients who are dragging a catheter with them without knowing that we can do this green light laser without taking them off blood thinners. So that's something which I want to convey to not only patients, to my primary care physicians and cardiologists, that green light laser can be done with the patient still on blood thinners. And also prostate microwave therapy can be done in the office when the patients are still on blood thinners.
Thank you so much, Dr. Chakrabarty, for your time and expertise in providing some valuable information to our viewers on urological health for men. I sincerely appreciate your time to come to MedTalk for interview from your busy schedule. And I wish you all the best in serving your patients and staying healthy as well. And wanted to wish you all the best for your bid for the Vice President for AAPI in your upcoming elections coming up. Thank you so much.
Thank you, Tusharji, and thank you, Indus TV, and appreciate you having me here.